Good morning. I think we're going to get started, so if you could take your seats, that would be awesome. So I want to welcome everybody to the annual scientific session of the Myasthenia Gravis Foundation of America. We have some terrific presentations today. It couldn't be a more exciting time for people living with myasthenia gravis than now. The research that's happening is pretty amazing. So I also, before I get started, I want to introduce our session leaders who have worked so hard to put this together. Dr. Guptill, Dr. Hare, and Dr. Guidon. I think you know most of you probably know them already, and I'll turn things over to them in a second. But before I do, I wanted to tell you a little bit about MGFA. We are not your grandfather's Myasthenia Gravis Foundation of America. We are really changing our organization and becoming more integrally involved in the MG community, starting with research. One of our goals is to leverage dollars from MGFA, from our donors, to bigger projects, and we've certainly seen some success. I saw Linda Kushner here a few minutes ago. She's around. I'd like to mention that she will be the next chair of our Medical and Scientific Advisory Board, and Dr. Guptill will be our vice chair. So we have great leadership, and thanks to Robert Ruff, who is getting to hand over these duties at lunch today, which he's probably pretty grateful for, but we're not letting him escape. So, there we go. So the baton. So anyway, these dollars that we leverage, in 2010, Dr. Kushner did some research on complement inhibition, and we all know how exciting that is in MG treatment potential right now, with fingers crossed that we may see something approved this fall for that. And also the consensus treatment guidelines, which were funded by MGFA, has now led to a large grant from PCORI to investigate outcomes in treatment in MG. So we're really excited that we see our plans working. You'll see with your materials where you're sitting is a brochure for our patient registry. Thanks to investment from the MG community and leadership from patients, we have nearly doubled the size of that registry in this last year. So we're up to more than 2,000 patients, and we're seeing usage from industry, which is really exciting. So please, we're happy to send you brochures. We're happy to send you MG literature. We're happy to send you what you need for your patients, and we no longer charge for literature, so please, by all means, ask for what you need. We are excited to have one of our fellows. Dr. Rhoda is here today. We're really excited to have him with us. And I wanted to also announce that we have made a commitment to fund another fellow in 2019. So please, if you've got good candidates, we're pretty excited with the results, with two of them sitting right here with us, as well as Dr. Rhoda. So we're excited with the results that produces. Our pilot grants will be determined for this year this week, and we'll be doing our cycle, I hope, earlier, and so we would love to see applications from you for that. We're also looking at establishing standard diagnostic criteria for MG and related disorders that we can make sure we get in a convenient way to the people who are likely to see patients first: ophthalmologists, pediatric neurologists, primary care doctors, who may be the ones who are seeing the symptoms but not recognizing them. So we're hopeful with that. The cure for MG may come from somebody in this room. So the work that you're doing is really exciting, and we're so happy to have you. I also wanted you to know that we're launching a new program to better engage clinicians in the work of MGFA, and to also ensure that people with myasthenia gravis can find the people who are like you, who are here today, who are interested in treating people with MG and who are making a difference in that. So our new program is Partners in MG Care. It is loosely based on a similar program that we launched at the National MS Society during my career there. And you'll see a brochure about it there. We've got more information. Today is the day. MSAB members, you'll get an invitation to be a partner in MG Care, but there's others of you as well, and we hope that you will take advantage of that, and we'll be searching for people so that when we launch our new website in January, we will have a searchable feature so people can get on and they can find clinicians and get information about you who want to treat people with MG. So you'll be hearing more about that and seeing more as time goes on. You'll also see opportunities to get involved in MG. So many of you here in this room have been partners with us at our MG Walk. Our patients love to see you there and to meet you and to know that there are people like you working on their behalf. So we hope that you'll think about that. There's opportunities to be a speaker at our national meeting or at local support groups. Would love to have you. There's MSAB committees that we are looking to staff, and if you're interested in working on any of those committees, we would also love to have you. And you'll also see there's an infographic there on your table that is a simple thing that you can put in your office. It's also something that people can put up in grocery stores anywhere that people might see and answer some questions about myasthenia gravis. So if you want more of those, please do that. I'd like all our our MGFA board members to raise your hand or stand, and we can thank those people who work so hard on our behalf. It really means a lot to us. So, and our MSAB members as well are here. If you'd raise your hand, that would be great. And I thank you again. I think every one of these people is volunteering on one project or another, and we appreciate that so much. I want to thank Alexion, who is our sponsor for this meeting and has been a great partner and helped us out with some other projects along the way. And now I think I've covered what I need to, and I want to turn things over to our panel. So, gentlemen and Amanda, that would be great. That would be great. Thank you. I'll say yes. I'll take it on the left-hand side, though.
So on behalf of my co-chairs, I just want to welcome everybody to the meeting. Thank you for all of your submissions, and thank you for making the trip down for the meeting today. We have some really nice presentations for you all. So just a couple of logistics. So the meeting is broken up into platform presentations, talking posters, and posters. The platform presentations are going to be 10 minutes with 5 minutes for questions. The talking posters will be a 5-minute presentation with 2 minutes for questions. We've set up the room to try and facilitate talking posters. The talking posters are on your right in the back of the room. We'll congregate back there during one of the breaks, and we have some wireless mics that we can use for those presentations. The only update to the schedule is that the 9:15 9:15 platform presentation is canceled today. So there is some buffer in the schedule. We hope to be done closer to noon than 12:15 today. So Dr. Gupta will introduce our first speaker.
Thank you, sir. First speaker will be Dr. Sri Mupidi from Stanford University, who will be talking to us about incorporating clinical outcome measures into practice.
So thanks for the committee, and thanks for inviting me to give this talk. This talk is really an overview talk, so I don't necessarily have new data to present. And hopefully at the end of this session, I might have changed. If I change one mind, that's great. If I change more than few minds, that'll be a real success. So before I get started, I just want to ask you to raise your hand how many of you routinely use any MG outcome measure in your practice? So that's really good. But please remember that we are probably the exceptional crowd in here. These are physicians who see a lot of MG, and the goal is that maybe we can encourage others to do the same. So my objectives for the session, just to review a few handful of validated MG measures. There are quite a few of them, but I will only review about 5 of them. And how do we use them in practice, how to make it a smooth process when you start using them in practice, especially if you're going to try to use it for the first time. And I'll give you sort of personal anecdotes from my own experience from moving from one institute to the other. It's never as easy as just get started. And then I personally think that we need to move towards much more objective evaluation of MG patients in our clinical practice. And some of these tools are, in my mind, fairly easy to use, that it's quite easy to implement. You don't need a lot of help or technology or instruments, or hopefully not too much time. So as I said, there are a lot of MG outcome measures. A lot of them have been validated and tested with appropriate psychometric testing. I won't belabor the psychometric testing for each outcome measure, but I'll just give you an idea about what are the different psychometric testing that have been used. The MG outcome measures vary as to who does the test and who evaluates the test and how it's performed. So there are MG outcome measures which are purely physician tested. So the physician has to be involved with every item that's being tested. There are MG outcome measures where the patient is the only one who reports their symptoms, or their activities of daily living scale, or their quality of life scale. And there are mixed ones where there is, in the whole scale, there are some which are physician reported and some which are patient reported. And some MG outcome measures require training and equipment, which if you are in a clinical trial is not a big deal, but if you are doing it in clinical practice, and if you are a busy clinician and you move from one room to the other, it adds sudden hiccups instead of moving on, unless you have a lot of help in your clinic. So that's one of the limiting factors about that. Briefly about psychometric testing, pretty much all of these MG outcome measures I'm going to talk about have been sort of properly evaluated. Psychometric testing involves many different components. So it looks at validity of the test. So you want to actually make sure that the outcome measure that you're using is testing what you think it's testing. So it's testing their MG-related symptom score, or all the features of the questionnaire are related to MG. You want to make sure that the test is a reliable test. So if I were to administer the test 10 minutes apart, 1 hour apart, 2 hours apart, or 10 days apart, when there is no change in the patient status, the score should be almost the same. And then you also want to make sure that it's responsive to change. So if you were to treat the patient with any medications, and the patient has improved, the score should improve. And you ought to know what the sensitivity and specificity of the change for sort of assessing improvement in patient. And then there is further analysis called rash analysis, which looks at sort of different items in a score and the value of different items. I'll say that a lot of these MG scores that I'm going to talk about have been tested for almost all of these features. Very few of them being tested right from the beginning. As it happened in the MG community, the scores came about, and others sort of came along and said, okay, we haven't done this particular test to sort of look at the validity of the score, or whether it's a reliable score. And so that's ideally, if you were to come up with a new score, you want to do all of that right from the beginning. And then I'll talk about one outcome measure that's coming up. I think that they're using that kind of principle. So we'll get started. The first one, I think most of you probably are aware of it, especially if you ever participated in an MG trial for any drug. This would have been used. So the quantitative MG score used to be an 8-item score, but then it was later changed to a 13-item score. Each item is scored from 0 to 3. 0 is no symptom, and 3 is severe symptoms. It's a linear score, and I'll point out some of the disadvantages of having a linear score. And then naturally, the 13 items, so the range is from 0 to 13. 0 would be normal. 39 would be the most severe form of MG one could have. It does require some equipment. Spirometry or FVC calculation would be one of the measures that you need to do as a part of the test. It also requires a handheld dynamometry to measure sort of hand grip. There is a little bit of a training involved just to make sure that you follow the steps appropriately. So those are some of the limitations if you want to routinely do it in practice. I know groups around the country where they can do this in practice. Having spoken to many colleagues, that most physicians to do this in routine practice would be sort of very, very difficult to do. And then just talking about the item distribution of the QMG. It has 2 ocular items. It has 3 sort of facial, pharyngeal, or bulbar items, and 8 non-facial items. You do want, if you want to use an outcome measure, you do want something that sort of measures different spectrum of MG symptoms, because MG can be generalized, bulbar, ocular. You want a component of each one or some of those so that you can actually measure different patients across time. And it does take maybe 20 to 30 minutes. Because it uses a timer, I'll show you in a second, because it uses a timer for a lot of the measures, if somebody is not as symptomatic, it'll take longer. If they're actually severely symptomatic, it won't take as long because they would get weak or fatigued earlier in the time. And so you use a stopwatch. And so that's one limitation as to how long it will take. But it's a really comprehensive measure. It gives you a really sort of overall picture of their MG status. But one problem is the linear score. So for example, if you just follow, let's say, speech. So if you don't have any speech problems, you score 1 or 0. And if you have severe dysarthria, you score 9, except, that linear change from 0 to 3 is the same linear change for ptosis, same linear change for diplopia. And most of us would probably think that's probably not the right way in terms of our urgency to treat a patient, what we would do a patient who cannot swallow, cannot speak, versus a patient who has severe ptosis might be slightly different. Likely that 0 to 3 change has different values for different items. And that's one limitation of having a linear score, is that in reality, even though every item moves from 0 to 3, the value of moving 0 to 3 depends upon the item that you are measuring. And that's one of the limitations of some of these scores which have linear scoring system. It has, as I said, it has 2 ocular items, and then it has 3 facial bulbar items, and everything else is either neck or limb items. So just to briefly finalize on the QMG side of things, it's been used in multiple trials. If you were fortunate to participate in any of these trials, you would have had some experience using it. And so that makes it easy if you do want to incorporate it into your practice. The clinically meaningful change has already been defined by testing. It's about at least a 3-point change. Higher would be great. One limitation, apart from it being a linear score and how long it takes, is that it doesn't actually reflect the patient's disability or the disability experienced by the patient. You're getting a completely physician-reported score. The next one I'll briefly talk about is manual muscle testing. And for most neurologists, this is really a easier score to comprehend. It's, again, completely physician-reported. It has 18 items. All of them are essentially strength testing. 12 of them are bilateral, 6 midline items. And it has a linear scoring system. 0 would be normal, and 4 would be severely weak or plegic. And the range is from 0 to 120. And the item distribution, it sort of covers multiple areas. So that's something that you always look for in an MG outcome measure. And so that's a typical MMT. And then, as I pointed out earlier, it has about 18 items, starts all the way from ocular all the way down to lower limbs. It takes a few minutes to just read through this if you start using it in practice, just to make sure that it's different from your typical manual muscle testing that you would do in clinic for a neurology patient. The second thing is that, let me just go back forward a little bit. It has 3 ocular items, and then it has 3 bulbar items. And some of these are, they're midline items, so they only score once rather than right and left. Everything else scores right and left. Again, has been used in trials. There is no need for any training. If you're neurology training, you should be able to do this pretty easily. If you want to use this, one additional advantage is that this could be part of your exam for the patient, because most of us would want to be able to do some kind of exam in our note, and so this would be your exam, and you don't have to do an additional exam beyond it, because it pretty much covers everything MG related. And so that's the main advantage. The disadvantage is that, again, it doesn't clearly reflect how a patient feels about their MG care or the disability that they might be experiencing with MG. That's a uniform theme when you have a purely physician-reported measure, is that you don't get a true sense of how a patient is doing at home. You get a sense of different snapshots in time, every 3 months, 6 months, however often you see the patient, how they did that morning or that afternoon. And as you know, there's a lot of variability in how a patient does at a different point of time in MG. So that's something to keep in mind. I'll talk about a couple of measures which are purely patient-reported. They have their own advantages and disadvantages. One of them is MG activities of daily living. This was adapted from QMG, looking at the questionnaires from QMG, but adapted for a patient-reported symptomatology. It has 8 items. Again, has a linear scoring system ranging from 0 to 3. It won't take more than 5 minutes to do it. It is physician administered because a couple of questions need to be explained to a patient occasionally. And it has a pretty broad spectrum of sort of item distribution involving different MG-related weakness distribution. And then the cumulative score ranges from 0 to 24. And so this would be a typical MG-ADL score. As I said, it's a linear scoring system from 0 to 3. It has multiple items. And so, for example, it has 3 bulbar items talking about talking, chewing, and swallowing. And then it has 2 ocular items, double vision and ptosis, and rest of them are generalized items. One main limitation is that even though it's physician administered, it has no axial items. So let me go back and just point out that limitation. It has no axial items. If you've seen, I'm sure most of you have seen, if you have a patient with head drop from myasthenia, this won't really reflect how they're doing, because they might be profoundly disabled, as you would expect them to be, but this score actually doesn't reflect what's happening with their head drop. So those are some of the sort of subtle limitations as you start using them or thinking about adopting them, need to just keep in mind. But otherwise, a sort of a 2-point change has been shown to be clinically meaningful, and it's a fairly sensitive measure for treatment response, so that's a nice feature. And as I mentioned, it doesn't have an axial item, so something to keep in mind. And the last sort of purely patient-reported measure is quality of life. Before the MG-specific quality of life measures were created, there were no sort of, the quality of life measures were, in general, quality of life measures that are used for multiple neuromuscular and neurological disorders. And then Ted Burns and his team initially created a 60-item sort of MG-specific quality of life, which could be used in research studies, but for clinical purposes would be really a difficult one to adopt. And then they changed it to a 15-item, the second Q, so we call that QOL 15 to indicate the 15 items. And the 15 items cover across the spectrum of potential MG-related quality of life limitations. And each item ranges from 0, so no limitation at all, to 4 very much, and the score is 0 to 60. So this would be a typical MG-QOL-15. I know many practices routinely do this. In their practice, they get the patient to fill it out while they're either checking in or at the time of checking out. And so by the time the physician walks into the room to see the patient, this data is available, and they have access to the previously filled out data. So it makes it easy to understand what's happening with the patient longitudinally or multiple clinic visits. One addendum with the Quality of Life QOL-15 is that it's been recently revised to a sort of a revised version, and probably even more easier. It still has the 15 items, but ranges from 0 to 2. Overall, this revised version has a better sort of clinometric properties, and on rash analysis it did much better, and so that's why it was revised to this newer version. And this is, if you are thinking about using a QOL, this would be the one to use because this is probably a better performing QOL measure than the initial QOL-15. Both of them are very easy to use. I'll briefly talk about a couple of measures which are outcome measures, but they are combined outcome measures. So they have both a physician element as well as a patient element. And I personally like these measures because they truly reflect both the patient side of things in terms of how much disability they might feel from an MG, and then the physician might feel like they actually can corroborate that, and they have some role to play in looking at a measure that, if you're especially looking at it to evaluate changes in treatments and how you go about treatments. So the first one is MG Composite. It's a mixed outcome measure. It was developed by taking items, the best performing items from the previously mentioned 3 outcome measures, MG-ADL, MMT, and QMG. It has 10 items. 6 of them are physician evaluated, 4 patient reported. One additional advantage of this was that it's a weighted score. So it doesn't move from 0 to 4 for every item, and I'll show that to you. As I pointed out earlier, there are limitations if you move in a linear scale, because as we all would agree, different items have different value of significance, severity of disease burden, so on and so forth. And then the range is from 0 to 50. And so this is a typical MG composite. It has 10 items. There are some that are purely patient-reported, and then there's some that are physician-reported. But the key is that, as I said, it's a non-linear or a weighted item. So for example, if you look at breathing, somebody who's ventilator-dependent, they get a 9. And as you go down to from 9 to, let's say you have only shortness of breath on exertion related to MG, you get a 2. Most of us would agree that if you have a patient in the ICU, ventilator-dependent, and then you get them home and they experience shortness of breath, that's only on exertion, you've made a big difference to that patient at that point of time or in those weeks. And that's reflected by a 7-point change. Whereas if you improve the ptosis from severe to mild, it's reflected by a 2-point change. If it had a linear score, all of them would have the same degree of change, which I don't think is the right way to going about measuring some of these items. They should have differential sort of weightage because of the severity of certain symptoms. So that's one real advantage of this measure. And then it has 3 ocular items, and then it has 3 bulbar items, and then it has a neck flexion extension item that the MG-ADL didn't have, for example, and then it has sort of proximal limb items, and then shortness of breath. It's been, again, used in multiple trials. It's very easy to use. This is very easily adaptable into practice. So much so that this was actually recommended as one of the outcome measures to be used going forward in clinical trials because of how well it was tested and because of the differential weightage given to different items in MG. And a 3-point change was considered to be significant for MG composite. The last item, and this hasn't been fully studied yet, is called MG Impairment Index. I don't know if anybody is here from Dr. Brill's group, but they had published this data last year. So it's a recently developed MG outcome measure. Unlike previous measures, unlike the previous 4 measures that I briefly talked about, where we came up with an outcome measure based on different items we think are appropriate and then tested them, this was actually tested with the sort of the latest methods of developing different items. They came up with, I think, approximately about 80 items, and then go through different physician group, patient group, understand the importance of each item, and then tapered them down. And then FDA actually published last year guidelines on how to develop items, especially if you are thinking about using them in research studies. Because as you probably heard, different studies have used different items, and occasionally they miss out a significant p-value because of the item that they used or how they used it, for example. And those things make a big difference to the community. And we actually want to find out if the drug worked or not, and you don't want the item or the test that you used to be the limitation. It has 20 generalized items and 8 ocular-based items. One thing that they have not done is they did not introduce any weightage to these items, and their point is that we have so many items, so we have 28 items that we can compensate by the number of items without having a weightage. The content validity of this particular measure has been studied at one center. We don't quite know about the responsiveness to change, so that I think is in the works, but I don't have any data for that yet. So we want to make sure that the measure actually changes, improves if the patient improves, or gets worse if the patient gets worse. Because if it doesn't change, then it's not really that useful. But at least so far, looking at the content validity of the data, it does seem to pan out well. So for example, this is looking at generalized MG component score, the 20 items, between a patient with ocular and generalized MG. It clearly differentiates the 2 groups, as you would expect it to. And it also really does very well between patients who are in remission, minimal manifestations, and different severities of MGFA. And so if you were to create a score, you would want it to gradually get worse if the patient has a higher degree of MGFA classification. So those 2 are promising features, but I still think that we need to understand truly the responsiveness of the scale to improvement in patients. So likely they probably are doing a longitudinal study looking at that. And then I think this would be one of the measures that could be easily adapted because it's a combined measure. It has both physician and patient reported items. And if it's truly responsive to change, this would be something that I think we as a community can easily adapt. So those are briefly about five different items, different MG outcome measures that I wanted you to have an idea about. Some of you probably are using them in practice. A lot of them are easily adaptable. And from a personal experience, I don't know about the MG Impairment Index, but all the other items before that, all the 4, the QMG, MMT, MG-ADL, and MG Composite, there is no copyright on using it for clinical practice. That might sound absurd, but at my institute, when I wanted to use MG Composite, I had to get a letter from Ted Burns to say it's okay to use it, because our EMR folks wouldn't put it up on the EMR unless we got a written notice. And so those are certain things that you might come across just to know. So some of these are my personal recommendations from being at a couple of institutes. Where I did my fellowship and at the beginning of my faculty, we've always used outcome measures. And so using an outcome measure was no-brainer for me. It was the way I did it. I moved to a new center, and it took me a while to get going. It took me a while to convince my colleagues to participate in that process and explain the importance of the value added by using an outcome measure. And so I encourage you to think about, don't underestimate the resistance to change, including myself. Otherwise, we would all keep up all our New Year resolutions every year. right? It's difficult to change, especially if you practice certain way for a very long period of time. It takes a little while to sort of look at different aspects of clinical care. But, so it takes a little while, but it really is valuable if you use it for the very first visit that you see a patient. Because then you really get a benchmark for that patient, whether they're well or not well, or severely symptomatic or not symptomatic. You truly understand where they are in their sort of overall MG care. And then you can assess, just a neurological examination might or might not help you understand the impact MG has on a patient. And so some of these outcome measures provide that extra value if you use them in practice. And then this line should go to Ted Burns' line. I could never come up with such vivid description, but he had a very valid point that if you use an outcome measure, it provides you sort of a 24-hour or longer video of what's happening with the patient rather than a snapshot that you get when you see the patient and examine them quickly in your clinic. And most of us would want a bigger picture so that you can have the patient on your side when you suggest treatment changes or alterations in their regimen. And I personally think using outcome measures will truly get you a sense of sort of monitoring responsiveness to different treatments. And I think this is an important measure because if you were to put up MG in clinical trials, there are so many new interventions, so many different mechanisms coming up in terms of treatment. And I'm no health economist, but I think they won't be cheap. And so we probably, as a community, has to figure out if a patient is responsive to a particular treatment. So you want to assess that quick, if you can. Or they're not responsive to that particular treatment so that you're not exposing them to this extremely expensive, potentially toxic, or potentially immunosuppressive therapy that they were never going to respond. And if you want to assess improvement or lack thereof, let's say in 3 months, using an outcome measure will make it easy for you to document that objectively, whichever response you're looking for. And then there is a possibility that if you have a practice that, let's say, covers a state, and you have patients who are being sort of co-managed by you and then a local neurologist, there are some of these measures that could potentially be done remotely by the patient, and you can have access to that data, or you can work with a local neurologist to look at some of this data and see what's happening between the clinic visits with you. And so that really sort of allows you to participate in patient care, even remotely. To me, and I think most physicians, when I talk about this issue, they'll say, this is all good, right? But most of us would have, let's say, 25 minutes to see an MG patient or 20 minutes to see an MG patient. And time tends to be the biggest limiting factor because there are so many other regulations that you want or you need to have in your clinical note or clinical assessment. And so this becomes another extra item. And this is not mandatory, so all the mandatory items obviously take precedence. And so time issue, I don't have a solution for time issue, but that most physicians tell me that tends to be their biggest issue in terms of using an outcome measure. And so my only solution is to come up with one measure that works well for you. So you could potentially use one of these combined measures, which has physician and patient-related items in it. You could do just one measure. You don't have to duplicate a lot of work. It could be incorporated into your EMR, make it easy for you. Or if you say, I would like have the control of doing my own exam, so you could potentially use an MMT, which is essentially a sort of a neuromuscular exam, and then you can have the patient fill out one of the purely patient-reported outcome measures before the clinic visit or during the clinic visit. Then you truly get a sense of, again, both from a physician side of things as to how their MG is progressing, and then you get a sense of what's happening with them from a patient side of view. If you might feel they're weak, but their patient-reported scores only get worse and worse at every visit, there is a difference, and I think we should know why there might be a difference. And patients need to understand what might be MG related, what might not be MG related, and so that's the only way to get to the bottom of that. And I personally recommend sort of incorporating them into medical records if you can, because doing sort of an additional piece of paper that you would fill it out and then add it into the medical records, again, that sort of builds into the time issue. For most physicians, including myself and a lot of physicians at our practice, time is the biggest issue. We don't have unlimited time. In fact, I'm just looking at how many computers are open. I'm sure a couple of you are on Epic right now as I speak, trying to reply to a message, right? That's just life. And so that's the physician world we live in. And so anytime you can incorporate these measures directly into the node, I think it saves you time. And so these are a couple of examples from our institute. Both of them are MuSK-MG patients who've had Rituxan. But I just wanted to point out how these are all drop-down menus. And so I only click the drop-down menu and quickly add it into as a flow sheet. And I don't need any fancy things. I just need to click the graph region, and I get a sense of what's happening with the patient over a period of time. And so this was a MuSK patient who was on multiple drugs, including IVIG, had Rituxan, gradually improved, and then she had recurrence of her symptoms later. So I didn't need to put this in Excel to create a sheet. It's relatively easy. It does take some time at the front end, getting your EMR to join in and then set up this for you. But once you set it up, it's relatively easy to start using it. Other important, couple more slides, I think. Other important thing is that other fields are already doing it. As much as I would like to say we are at the cutting edge of this, we're not. A lot of fields are already doing this all the time. So for example, in MS, there are so many drugs in MS. And so they already use a lot of the clinical sort of outcome measures that have been used in clinical trials into their practice. Most of us use ALS-FRS in our practice. That's incorporated into a lot of the EMRs. And I'm looking at you, and he might not like, but this actually slide is from UCSF. And they have this system set up for MS patients. Essentially, every MS patient who comes in, they longitudinally track their clinical data, their imaging data, serological data as to sort of one spot. I'm sure it took time to develop that kind of project. But if you were to think about it, think about the value that you would add to the patient in sort of longitudinally following patients with an outcome measure. And if you can incorporate different treatments that you've used and what was the response to the treatment to the outcome measure. I think that would be really valuable. That would be sort of taking care of the patient and designing the care for that patient rather than sort of a group of patients. And patients already use this, so I'm sure some of you have already seen it. I've had patients who use this app. It has both MG-ADL and MG-QOL 15 currently, and they fill it out ahead of time, and then they let me know what their score was, and then I quickly document that into my note. And it's a reflection that the patients are ready to take on some of these roles if we get them on board and sort of taking ownership of some of their MG disability and how to track it and how to monitor it. And the last slide, if at the end of this you feel like, well, this is all nice to hear. I just don't have time. And so we have creative people in the field. And so there is this one published study which says that you just need to ask one question. Just need to ask one question to get to the bottom of their MG. I don't completely buy it, but I thought it was a sort of a creative way of looking at a problem. And so the question is, what percentage of normal do you feel regarding your MG? 0 is, completely disabled. 100% is completely normal. And it does correlate with different MG outcome measures. My point is that there are a lot of creative people in this field. I think we can figure this out. Thank you very much.
I think we have time for a couple questions.
I'm George Small from Allegheny General Hospital in Pittsburgh. We're fortunate enough to have a clinic of approximately 200 different souls with myasthenia gravis. Originally, we were a private practice, and we transitioned in the last 10 years to being an academically bent institution. We've only been a year and a half on Epic, and we see lots of people taken out horizontally in ambulances. Those are physicians with it. Not to overstate the problems with it. What do you recommend? Having a representative from Epic come, sit with us, talk about which scales we want and incorporate them? Is that the method to do it?
So different Epic, even though we think as Epic as one unit, I've learned that Epic is, some places Epic is designed for the institute. For example, at Stanford, the Epic is truly designed for, like Stanford, for some reason, they're not necessarily the motherboard Epic. And so best thing that I have done, trying to get them in, is that I've called them and we sat down and I said, I would like to get the MG composite into Epic. What is the best way to get it in? So, and I'm not an Epic expert, but if you get that into your note, the way currently the Epic note is designed, the data in an Epic note is not easily extractable. And you can't look at discrete data over a timeline. Like, for example, if you want to graph it the way I showed it to you, at least at our center, you can't graph it. So there are different options. There's a sheet called flow sheet, which is currently used in Epic for a lot of the inpatient measures. So looking at a temperature over a period of time, heart rate, blood pressure, so on and so forth. And so that was the one that they suggested. If I really want to be able to extract data, graph it quickly, they suggested I use the flow sheet. And it wasn't easy. It took me a while to get them to do this. And then, you come across all these problems that they have not used to because, for example, if you're looking at heart rate for an inpatient, that's measured every few hours. And so after we created the flow sheet, we realized that the scale was only a few hours to a few days, not every few months. And so I couldn't actually access the scale from 3 months ago because it wouldn't show up. The scale, so we had to go back and change it to months and years. There is some, iteration that needs to be done, but I think this is doable. Once they got it, it didn't take them that long to do it. If you want to be able to extract individual piece of data, I would recommend this sort of thing, a flow sheet or something that's outside the note, and it can still be pulled back into a smart phrase, pulled back into your note, and so.
Hi, Rich Lewis. Very nice talk. These measures that were really devised for clinical trials.
Sure.
And so in many ways, they're composite. And as you know, our patients sometimes have a lot of problems in one area and no problems in the other areas. Sure. So in terms of following an individual patient, these kind of work sometimes. If they get globally weaker, then obviously you're going to see it in almost any of the scales. Sure. So one of the thoughts I had about this, and I bring it to the MGFA because I think it's something we can consider, is in individual patients, I frequently ask them what are the 3 to 5 things that are most problematic in their life related to their MG, and I focus on those. And so if we had a smorgasbord of here are our bulbar items, here are our eye items, rather than looking at these composites, sometimes you get a more weighted evidence of whether the patients are, and clearly related to their function as opposed to whether their eyes move up and down a little bit. Sure. So I wonder whether that's an option that we should consider in the future.
I think it's a great question. It's a question about individualizing care. We talk about individualizing care, but maybe we should talk about individualizing the outcome measure that's relevant to the patient. Because if a patient has purely ocular, but they're severely disabled, and you only have 2 items that only move by 2-3 points, it really doesn't, it's not focused on the patient. It doesn't zoom in on his or her disability, and so you fail to pick up. It's a very valid point. And it could be that, we could potentially, the team here could potentially come up with items that are being used in different measures and say, these are the 5 ocular items, just like you pointed out, and then pick the ones that you think are relevant. But, the key point is, though, I'm not married to one outcome measure or the other. I just think that as a community, we should use them longitudinally. I think that's where the real value is, apart from obviously focusing on
but
patient.
in individual patients, functional outcomes in some ways are the most important things that we're dealing with. And your functional outcome measures are kind of buried in some of this. The ADL may be your best. Your QL has some functional measures in there. It's not a pure QOL.
Sure.
So getting a better functional, particularly for individual patients, becomes, I think, particularly important.
Yeah.
Thank you.
Thank you very much.
Okay, so we intentionally scheduled the next talk after Dr. Mupidi. So now Don Sanders is going to talk about a REDCap database that will incorporate collection of some of these outcome measures. And this has become particularly relevant with the recent funding by the Patient-Centered Outcomes Research Institute, PCORI, of a 3-year grant to look at outcomes of myasthenia gravis patients in a real-world setting. So Dr. Sanders, thank you.
Thank you, Jeff. And I was delighted when Dr. Mupidi published a paper very recently in which he made all of these points about keeping quantitative measures in the clinical record, because we think that's a great thing to do. And I'm going to talk about a way in which we have been doing something like this for a number of years in our MG clinic. I just realized that this slide does not include the other workers who participated largely in development of this REDCap database, Matt Small and Sue Budinger of our REDCap support team, and Jeff Gupta. How many of you here are currently or have in the past used a REDCap database for anything? So many of you know what REDCap is. It's an acronym, stands for Research Electronic Data Capture. It's a web-based application for building and managing online surveys and databases. And I would emphasize surveys here because it's online and it's HIPAA compliant and it's very secure. Patients can actually enter their own information for specific surveys, such as these outcome measures, these patient-derived outcome measures online. We recently converted our ancient Myasthenia Gravis clinic database to REDCap. Chip's chuckling because he was a major contributor to the development of our old database and has used it for about at least as long as we have. Right, Chip? Yeah, and still uses it. He's still wedded to the old. We'll see if we can convince him to switch to REDCap. What are the pros of REDCap compared with other database systems? I don't think this is showing up on the screen. The pros are, first of all, it's web-based. It's easily shared with other institutions who use REDCap, and many, if not most, academic institutions around the world use REDCap. As I mentioned previously, it's one of its major features is the ability to have online survey forms. It has all of the data assurance and security features built into it that are required by modern medical records, and it is HIPAA compliant. I don't know if you can read that yellow line there, but it has built into it a feature called data access groups, which means that if multiple sites are entering data into the same master database, then access to the data can be restricted in a way that a site can only access their data, whereas the central administration can access all of the joint data. Cons are, it's a flat spreadsheet, so it doesn't have the features that are automatic and very useful in related databases. Development of it is not particularly user-friendly. We have to go through somebody else, our REDCap support team, to do the development, though I'm given to understand that if you spend enough time, you can learn how to do it well yourself, and Jeff certainly has reached that stage. The data entry screens are not as intuitive as other databases, and the report capability and analysis capability is limited. You have to take the data out of REDCap, put it into some other spreadsheet system that you're familiar with, such as Excel, and do your analysis there that way. Our database uses the common data elements for myasthenia gravis that were developed by the NINDS as part of its Common Data Elements project several years ago. And these common data elements are available and can be found on the NINDS website. This is the way that the database, our database, is organized. There are two major, sorry you can't see this. Does anybody have a brighter? This is it. There are two major types of records. First of all, are the ones that we refer to as master, which are more or less fixed data. Yeah, but it's not showing on the screen. Or at least I can't see it on the screen. These are all relatively fixed data points, and they are broken down into 4 different screens. We refer to them as master, history, treatment, and snapshots. And then the next group are those that are related to a date. And we refer to these as visit-related forms. When you enter data into the master file or field, it turns red until it's been verified. And this is what the master screen looks like. Contains your demographic information, certain other information related to the patient and or the clinic. And then the history goes into details about the way the specific disease has involved the patient. Things like the date of onset of their initial symptoms. Our database is set up not only for myasthenia, but also for patients with Lambert-Eaton myasthenia. So when a diagnosis is entered into the history field, then the subsequent questions are limited to those relevant to that particular diagnosis. We keep a number of types of information that are probably unique to our clinic and wouldn't necessarily be of interest to anyone else. But one of the things that I've been interested in over the years is what was the initial diagnosis that was made to explain the patient's symptoms. And it's very interesting to go back through and see what sorts of things patients were initially diagnosed as. What do you think is the most common initial diagnosis for a patient who presents to any physician for myasthenic symptoms? Anybody want to yell out an answer? Stroke is certainly well up there. It's a gimme because that's here on the screen. Actually, it's myasthenia gravis, but only by about a few percentages over 50. So a little over 50% of patients get a diagnosis of myasthenia by the first physician who sees them. And then there's a whole string of other diagnoses that all of you, I'm sure, are familiar with, that our patients are given to explain whatever their symptoms are. won't cover that. But these are the diagnoses that we keep in our clinic record. Of course, you can change that for your specific clinic. And as I mentioned, whatever diagnosis you give then will determine what questions are asked to a certain extent. We have a form here for various characteristics of the patient's particular disease. I'm going to run through these fairly quickly. And then here, if I can read this, has to do with coincidental diseases and other clinical characteristics. Then we have a form for the various treatments that the patient may have received, the date at which a treatment was begun, and if a date is entered, then you get a field asking you what was the response, or if appropriate, what were the side effects to that particular treatment. Then we have a form here called snapshots. I had trying to think whether we ought to change this to high definition video in response to Ted Burns' suggestion, but I think we'll keep it as snapshots. And basically, this is a quick picture of the patient's status at several time points after the treatment was begun. We've selected 2, 5, and 10 years, and if a date is entered for one of those time points, then you get questions about the treatment at that time point, and very importantly, the response to treatment at that time point as defined by the MGFA class and the MGFA post-intervention status. So we have a quick picture of what treatment the patient had received prior to the snapshot date, and what that treatment has done to the patient. When we go to the visit-related fields, we have several different options, several different types of data that we can enter that are related to a given date. Antibodies that were performed at that time, EMG studies, and then the various outcome measures that Sri mentioned earlier, the QMG, MMT, the limb manual muscle testing score, the MG-ADL, et cetera. And if you check one of those boxes, well, here's the visit. You fill in a date there, and it calculates the duration of the disease. And then you can select here whether the patient is receiving any treatment or not, or has previously had a thymectomy. And here is where, for the given date, you enter in the severity of disease by the MGFA class and the MGFA post-intervention status at that date. For each of the outcome measures, you can enter either the total score, or if you want to enter the individual scores, you check the appropriate box. If you want to just enter the total score, there is then a field for that. And if you want to enter the individual item scores, then it gives you the form here where you can enter each of the individual items, and it'll calculate the total score for you. Similar data entry forms are presented for the MMT, Composite, and QOL-15R. And if you have indicated that the patient has Lambert-Eaton myasthenia rather than those previous scores, you get the option to enter these two outcome measures, the limb ADL and the lower extremity function scores. antibodies. If you check the antibody box for that date, then you can enter the results of various antibody testing tests. If you enter EMG, then you have the opportunity to enter the results of repetitive nerve stimulation tests in several muscles, or the neuromuscular jitter in several muscles, and which electrode you used to measure the jitter. At the end of the day, the patient has a dashboard. Each patient has a dashboard that lists here or indicates here which one of these forms has been filled out, and for visits it indicates whether there is just one or several visits. So you can take a quick look at a given patient's dashboard and get an idea of what results were entered for that particular patient. We began our database a number of years ago, and it currently contains information on over 1,800 patients with myasthenia, or some form of myasthenia or Lambert-Eaton syndrome, and over 17,000 visits. And at each visit, information is updated in the database and a report is printed. The report is useful clinically to the patient, to the physician, excuse me, and that utility to the physician, the clinical utility, provides an incentive for the physician to keep the database information current and accurate. And this is the sort of printout we get for each clinic visit. Unfortunately, this printout or this report is not produced by REDCap. It has to be produced by some other software, and what we use at Duke is an organization called Petagene, Pediatric Genetics Group, that developed the capability of taking REDCap data and producing reports like this. But this is the sort of report that we use in our clinic. At the top of the report are the demographics. Then we have the treatments listed. And then here in the middle, we have the visits, the information for each visit, so that you can visually follow the patient's various scores here in the left-hand columns and compare it with the various treatments here in the right-hand column and get a visual impression of the overall patient history. And then at the bottom are the, this is the middle section here, and then down at the bottom we have the snapshots at 2, 5, and 10 years, and at the latest visit, telling us what therapies they had at these had at these time points, and the response to the therapy at these various time points. So this REDCap database is available. We'll make it the data dictionary for it available to anyone who wants to incorporate it into their clinic. To modify it, you just go into the data dictionary and change the various fields to suit your specific needs. It's written in the most recent version of REDCap, version 7.0, which I think most institutions are now using. And if you have interest in it or want to have access to it, you can just send me an email. I want to point out that Jeff mentioned earlier that we're undertaking a PCORI study, a comparative effectiveness study of a prospective study comparing the outcomes of patients treated in different fashions, and we're going to be using a version of this REDCap database to collect the data for that study. Thank you.
think we have time for a couple questions.
So great talk, Dr. Sanders. So I have
Who
a
is
question
saying that?
over here.
Oh, you're saying okay.
So it struck me when you put up your last slide of that face sheet for a patient with myasthenia. This is something that I've been thinking about in my own clinic, that would be the most ideal thing in clinical practice if you had an electronic medical record chart. If you could open the chart and that picture would be there about each patient. And I'm wondering if you've tried to incorporate the database with the EMR at Duke.
Tried, dreamed of, perhaps, and it may be some point in the future that will actually occur. But if you've tried to get anything incorporated into EPIC or the EMR like this in your institution, you can appreciate what it'll take to bring that about. So I'd like to think of this as a stopgap measure that could be used until and unless EPIC catches up.
The neurologists at our institution can provide all the enthusiasm as well as the patients for participating in this. Being 99% clinical, my question is, our bosses at the institution, I guess, would have to go through a certain vetting process and a HIPAA process and so forth before they said, yes, you can take our patient data and participate in this. Is that a fair statement?
We consider this database to be clinical, as does our IRB. If we want to do research from the data that's in this database, we submit a protocol to do so. And it's the same sort of protocol you would have to submit if you were to take any information out of the clinical record. And
But
it's pretty straightforward.
To even participate in it, I work at a university center, a Temple affiliate. I take it they would have to approve of our patients submitting data to this. I assume that's I would take it that would be a yes. They would have to agree to this.
Our IRB does not consider it to be research because we're using it for clinical purposes.
Thank you. I'll take it up with our people. Thank you.
Our next speaker is going to be Dr. Howard, presenting on the efficacy of eculizumab is sustained over 52 weeks in patients with acetylcholine receptor antibody positive refractory generalized myasthenia gravis. Interim results from the open label extension of REGAIN.
Thank you, and thank you to the committee for allowing us to continue to bring you up to date on the results of REGAIN and the open label extension trial. Many of you are aware of the results of REGAIN presented a year ago at ICNMD, and we're going to build on it today. The requisite disclosures. So, as you know, eculizumab is a humanized monoclonal antibody directed to the C5 component of the complement system and has been shown to be well tolerated and efficacious in patients with AChR positive generalized refractory myasthenia gravis during a 26-week program. These patients demonstrated a fairly rapid, robust, and sustained clinical response using a variety of outcome measures that Shri has already talked to you about, the primary endpoint being the MG-ADL score with secondary outcome measures of QMG, Composite, and QOL, against a backbone of a variety of immune suppressive therapy with or without chronic plasma exchange or intravenous immunoglobulin. This graphic depicts the overall study. On the left is the actual REGAIN trial and the rollover into the open label portion. Patients were evaluated, screened, randomized, having been immunized against Neisseria, and then in a one-to-one randomization went to investigational drug or placebo. They were studied for 26 weeks and given, had they completed that course of investigation, the opportunity to participate in an open-label extension trial. In order to maintain blinding, because not everyone had completed the original trial, the rollover induction continuation, if you will, was blinded, as demonstrated here. Those on active drug were dosed with their usual regimen on day 1, week 2, and then continued on every 2 weeks, receiving 1,200 milligrams of eculizumab intravenously. Those who had been originally on placebo required an induction dose of the drug and were treated weekly for 4 weeks with 900 milligrams intravenously on day 1, week 1, 2, and 3, and then began their every other week 1,200 milligram infusions. The data that I'm going to show you relates to the open label phase through week 26. You'll see some additional points thereafter, but we're going to focus on those first 26 weeks because everyone had completed that portion of the open label extension trial. We used the same assessment parameters that were used in the original Regain trial with a primary endpoint being the change in mean ADL score over time from baseline, with secondary endpoints involving QMG, MGC, and QOL-15 over the same timeline. In addition, we looked at tertiary endpoints and change of the median or the mean change in ADL subdomains, ocular, bulbar, respiratory, limb, etc. And I'm going to show you that data as well. And in addition, safety was a primary concern or a primary component of this, and I'll show you safety data through this period. The study is still ongoing. People remain in the open label extension phase, and our interim analysis was defined as of September 21st, last fall. And that's the data that we'll focus on today. This is just to show you patient flow. Originally, 126 patients were randomized for Regain, the blinded study, in a one-to-one fashion. One patient who was randomized was not treated in the treatment arm. So 62 in this arm, 63 here. At the completion of the Regain trial, 57 had completed all 26 weeks, 61 in the placebo arm, and there were 2 discontinuations in placebo, 5 discontinuations in the treatment arm, which we've already talked about in prior meetings. So 117 patients were rolled over into the open label extension. There was 1 in the treated arm who declined. Everyone in the placebo arm rolled over. And as of September 21, we had these numbers continuing on through the open label extension. 7 discontinuations from the original investigational treatment arm. 1 was an adverse event. 1 was a patient death. She was not on eculizumab at the time for at least 3 months. 3 patients withdrew. 1 discontinued by the physician, and another decided to stop. In the placebo group, original placebo group, there was 1 adverse event that terminated, and 5 patients withdrew during the course of the trial. The next series of slides are going to be very similar, and just as an overview, the left side of the panel depicts the original Regain trial data. The vertical bar as shown here is the rollover point after 26 weeks of therapy, and subsequent to this is the open label extension phase. If we look at MG-ADL with the original Regain, as you all know, there is a very rapid improvement in ADL that was robust and sustained through the course of treatment. In the placebo arm, our nemesis, the placebo effect, was there, as shown here. At the time of rollover, the important feature is that those who had received placebo initially had then a very prompt and rapid reduction, improvement, if you will, in ADL scores that then paralleled those who had been on eculizumab consistently from the start of the Regain trial originally. And this clearly, to me, represents drug effect. If we then take this panel and expand it a bit here and then normalize everything to baseline at the time of rollover, one sees that those on active drug originally maintain their effect through the course of 26 weeks, and those who originally were on placebo, who then received eculizumab, have again a very prompt, rapid, robust, and persistent effect related to a drug, and highly significant at less than P05 and P001. This same phenomenon is carried through with every measure that we encountered to one degree or another, and let's review the domains of the MG-ADL. And so if we look at bulbar domains, one again sees the original Regain improvement. Here's the placebo effect. And then upon receiving active drug at the time of rollover, a rapid, prompt, and robust improvement in their score that then parallels the original treated population. And if we expand that here and normalize, as I showed you earlier, here is the original treated arm maintaining their effect, and here those who receive eculizumab for the first time demonstrating this very rapid response that then remains and is sustained through the course of observation. If we look at respiratory domains, Regain on the left, originally rapid response, robust and sustained, that is then maintained through the course of treatment at 26 weeks. Here, those receiving placebo initially, then receiving drug. Again, not as robust as we've seen in the past, but remember, we only have one component here, but it is there, it's significant, and then persists. And again, expanding this and normalizing to baseline, one sees this phenomenon with original persistent treatment with ECU, and then the rapid and significant responses at each time point thereafter for those who are converted placebo to active treatment. This holds true again in the limb domain, and in blue, original treatment with eculizumab, rapid, robust, sustained through the original 26 weeks. Here's the placebo effect that we saw, but on rollover, a prompt, again, improvement, rapid, very rapid, markedly improved, robust, and sustained through the course of observation, again, paralleling the original treatment arm that crossed over. Expanding that and normalizing it, as you've seen in the past, here's the original treatment with ECU in both arms of the study. Here, those crossing over into the open label extension, now receiving active drug. and one is struck by the rapidity with which it works, the robustness of the improvement, and the sustainability through the observation period of 26 weeks. Again, similar course with ocular domain. Original treatment with ECU, here's placebo, now receiving ECU, and again, a very similar response that you've seen with the other domains. Again, normalized to 0 for baseline, persistent effect, and significant effect in the ocular domains. So each of the domains improves with eculizumab. There was original concern that perhaps ocular involvement would not, or that some of the other domains would not be significant, but clearly we're seeing effect to the entire body as opposed to selective improvement in one domain or the other. If we look at overall QMG and the change in QMG from baseline here in the original regain study, again, a very similar rapid, robust response to those randomized to investigational drug. Here's the placebo effect of those in the placebo arm. Those receiving eculizumab originally continue and maintain their effect through 26 weeks in observation. Those receiving placebo and rolling over to active eculizumab treatment, again, a rapid, robust decline in their scores as shown here. And then again, normalizing to baseline, one sees this response that's highly significant in all of the points measured. Composite, very similar effect. Regain, placebo, active treatment, clear separation, rapid, robust. That's maintained in the original treatment arm. And here we are with placebo, again with a very rapid, robust, and sustained response throughout the entire observation period, which is again demonstrated once we normalize to baseline at the time of rollover, that those receiving active treatment persist. Those receiving eculizumab for the first time have this fairly dramatic, rapid, robust, and profound response. Again, highly significant from a statistical perspective. And then we have QOL. The QOL change is not as dramatic as we've seen in the other domains and other metrics that we've used, but it's clearly there. A slower slope, if you will, that is then significant at the end of the regain blinded portion. Here's the placebo arm. Those receiving eculizumab throughout the entire course of events maintain their response. Those receiving placebo, again, have a fairly modest reduction in scores, although not as rapid as we saw with the other metrics that we've used. Normalizing to baseline at the time of rollover, one sees that this change is sustained for those on active treatment in both studies, and those receiving ECU for the first time, again, robust, sustained, persistent response that is highly significant. When we look at safety throughout this, it is no different than what we saw in the original regain trial. It's no different than that reported with PNH and AHUS, the two approved indications for this drug. Similar numbers had serious AEs. There were discontinuations in both arms. Those that reported exacerbations was more in those receiving placebo crossing over to active treatment, but not substantially significant, and similar numbers receiving rescue therapy during the course of their observation. The common AEs that were seen include headache and nasopharyngitis, some with diarrhea, These are myasthenic exacerbations here, and some joint pain, URIs, nausea, and pain in the extremities. These adverse events, other than the MG worsening, have been fairly mild to moderate. None were what I would call exceptionally severe and appeared in both groups equally. And so in conclusion, this interim analysis in AChR positive, generalized disease, refractory to therapy, and as you recall, it was having failed 2 immune suppressive agents over the course of a year, or failed 1, but required ongoing chronic treatment with plasma exchange or intravenous immunoglobulin. Each of them demonstrate, or the study demonstrates, that these patients can be improved with the use of a complement inhibitor, eculizumab, and that this effect is sustained over a 52-week period, 26 weeks in the original regain, 26 weeks in the open label extension phase at our interim cutoff date of September 21 last year, that this effect is consistent across all of the domains of the MG-ADL, that the response in those going from placebo to eculizumab is rapid, it's robust, and it's sustained. The safety profile is consistent with what's been observed before. No new signals were observed. I will call to your attention that no meningococcal infections were observed. Remember that inhibition of complement increases the risk of encapsulated infections, thus the need to immunize at least 2 weeks prior to the administration, or if that's not possible, covering them with antibiotics during that period of time. And finally, these results demonstrate the consistent, the rapid, the robust, and the sustained effectiveness of eculizumab in this patient population. This is just a list of our investigators without whom this would not have been possible, over the sites around the world, and also to thank our patients, our coordinators, and the support from Alexion, who funded this study. Thank you very much.
We have time for a couple questions. Dr. Ruff?
I think that this study, prior studies, have shown that for MG that involves complement, and so far those forms other than congenital MG and muscular MG, that eculizumab is extremely effective. The problem I have with eculizumab is the cost. How much is Alexion currently planning to charge?
Yeah, I have no idea what the cost of the drug will be should this become approved. But let's look at Spinraza. Let's look at Radicava. Look at all of the newer therapeutic agents that are coming online for genetic therapy, not only in neurology, but other disciplines as well. This is a pricey drug, no question, but I have no information on what the ultimate cost will be to our patients. Gil.
Yeah, Chip, very nice. And I think this again bolsters what I thought was impressive data that you first presented last July in Toronto. It's 14 months ago now. So two things. How much of this actually, either the safety or efficacy, goes to FDA for the open label extension? Or do they care about the efficacy data?
I think the efficacy data and the safety data go to FDA. It went to EMA, which, approved the drug about a week and a half, 2 weeks ago, and they have seen open label extension data. It's public domain out there already.
Okay, and then the second thing is, so rescues occurred, I guess, in 1 of 5 patients. It was around 20%.
Yep.
What did that entail? Could that have just been a bump up, say, in a prednisone dose, and they got put down in that 20%, or was that actually an exacerbation that led to a plasma exchange or something like that?
These are exacerbations leading to plasma exchange.
All right, so it was. So it's still 1 in 5. All right. And was that early? When was that? Was that early?
I'd
or,
have to go, yeah, I don't have that in the top of my head. I have to go back and pull that.
One more question.
Probably a quick question. The extension phase, in the extension phase, everybody's on treatment, right? But you showed a normalized chart of what patient would have behaved. Where does those data come from?
So just let me clarify. Pardon?
The-
Yeah, the question is explaining the normalized chart. And so the bottom left-hand graphic shows the actual course from onset of regain to the end of regain to rollover into open label extension phase. I'm taking this portion of the data here only, and that's this, and then taking it from the actual value to change from the point change from 0, from the time they rolled over, from the time they roll over, this becomes 0, and then what's the change from 0 in subsequent observations? So everybody now starts at 0, and one would expect there would be very little change in the treated arm, ECU arm, because they're maintaining their effect. But those who receive placebo initially should get better. And that's what we're showing here, that upon receiving active drug, they then develop this fairly dramatic change in that particular measure. Does that explain it?
I think I got it.
Okay. Matt?
Chip, it was a nice presentation. So going back to Bob Ruff's idea, thought about cost, is there any, either in the other diseases in which this has been approved, any idea that twice treatment every 2 weeks is actually necessary? Is it possible that going down the road that you could treat every 4, every 6 weeks? Is there pharmacokinetic and pharmacodynamic data that would allow maybe less frequent treatment going forward?
Yeah, that's an excellent question. And we know that complement inhibition is rapid, and then once you stop, the reactivation of complement is rapid as well. No one has looked at whether we can push from every 2 weeks to every 3 weeks. The half-life and all suggests it's a little more than, I think it's like 10 to 12 days, and then it's back up. But then you take phase 2 data, and remember we built in a 5-week washout period. And then crossed the populations over. So active drug went to placebo, placebo went to active drug. And the problem we encountered, and which sort of messed up doing statistics on the entire population, is that we saw this carryover effect, and that those who received eculizumab originally persisted with improvement through that washout phase that then slowly came back towards baseline. And I'm not sure we understand what that means. Is there persistent complement inhibition? One might not think so, given what we know about PK/PD data. Have we remodeled the receptors, the postjunctional membrane, and allowed the insertion of new receptors and have altered safety factor? Interesting. But we don't have a good answer, and no one has done this in an animal model, a mouse or a rat or whatever, and we don't have a good ligand at the moment that we could tag receptors with and then image them with SPECT or something.
Thank you. We're going to have to move on. Sorry. Thank you, Dr. Howard. So our next presentation is going to be from Dr. Sahai from UCLA about B-cell depletion and late-onset myasthenia gravis.
It's actually Cedars-Sinai. Thank you for the opportunity to present at this meeting. My name is Supreet Sahai. I'm a PGY4 neurology resident at Cedars-Sinai Medical Center. My co-authors on this presentation are Drs. Richard Lewis and Dr. Hattie Magzi. In the next 10 minutes, I'd like to summarize for you our experience with B-cell depletion in several patients with late-onset myasthenia gravis. I'm going to start out with a brief overview of late-onset myasthenia, which is classically defined as onset over age 50. Characteristic features include male predominance, and patients are more likely to have seropositivity and ocular involvement. The incidence and prevalence of late-onset myasthenia gravis have been rising, and this is probably due to a combination of the aging population itself, in addition to improvement in diagnosis in these older patients. About 20% of all myasthenia patients are considered to be late onset. Currently, late onset myasthenia is treated similarly to early onset, and there is no separate treatment paradigm for these patients. However, choosing the right medication regimen can be especially challenging, as these patients often have multiple comorbidities, including diabetes, osteoporosis, and an increased risk of opportunistic infections and malignancy. This greatly limits the use of corticosteroids and immunosuppression. B-cell depletion is another option for treatment in myasthenia gravis. Rituximab is an IgG1 monoclonal antibody that depletes B cells through specific binding of CD20. Although it has not been formally established as a treatment for myasthenia gravis, a recent systematic review by Tannen et al. Found that rituximab is effective in moderate to severe refractory disease in AChR and MuSK antibody-positive patients. It was also found to be particularly efficacious in MuSK-associated myasthenia gravis. Generally, rituximab is well tolerated, with minimal side effects, the most common being infusion-related side effects, which can be prevented by the administration of pre-treatment medications or slowing down infusion rates. Most notably, it is not known to increase the risk of malignancy. However, serious infections such as PML do remain a risk. To date, there has been one patient with myasthenia gravis who developed PML on rituximab. In this presentation, we hope to stimulate discussion and consideration that B-cell depletion may be as effective, if not more, than other immune therapies in late-onset myasthenia gravis. The safety profile in this age group may also be much better than other therapies. It also may be more cost-effective, and it also has better lifestyle benefits for patients. I'm going to go back really quick. Recognizing that we await trial results for data on large groups of patients and that only small series so far have shown benefits in acetylcholine receptor antibody patients, we propose that B-cell depletion should be considered as first-line therapy for older patients. So this is a retrospective case analysis of 6 patients who were diagnosed with late-onset myasthenia. 3 of them were non-responders to therapy, and 3 developed side effects to prednisone, including osteoporotic hip fracture, uncontrolled hyperglycemia, Cushingoid features, and shingles. These patients were followed up for 6 to 36 months. And with regards to the particular induction regimen or treatment regimen with rituximab, 4 patients received 2 doses of 1 gram infusions 2 weeks apart, which is the standard dose used in rheumatoid arthritis. One patient received 1 gram infusion, and another patient received 4 weekly infusions of 375 milligrams per meter squared, which is the dose used in most myasthenia case series. So here is a table with our patient characteristics. The mean age of onset was 66, with 5 of 6 patients being female. All patients were seropositive for AChR. 2 of 6 patients underwent thymectomy. The first patient's pathology was consistent with thymoma, and the second patient's pathology was consistent with thymic cyst. All patients were on mestinon, and as well as prednisone, with doses ranging from 15 to 40 milligrams daily. 1 patient was on cyclosporin, 1 was on monthly IVIG, and another was on twice-weekly plasmapheresis, which she was getting through antecubital veins. Adverse events to prednisone for each patient are listed here. Again, they include hip fracture, Cushingoid features, shingles, and worsening diabetes and hyperglycemia. 5 of 6 patients had myasthenic crisis, of which 2 required intubation. The MGFA class at onset ranged from 2B to 5, and patients improved to class 0 to 1 within a mean of 6 months after starting rituximab. All of our patients were able to discontinue or markedly reduce their maintenance medications, and 2 patients did not require repeat rituximab infusions for over 12 months. Most patients didn't have any side effects to rituximab. Patient 2 did develop pneumonia shortly after the infusion, which was successfully treated with antibiotics. And patient 5 did develop itchiness and rash during the infusion, which resolved after decreasing the infusion rate. Out of these 6 patients, we chose 2 that had the most dramatic response to rituximab, and I wanted to briefly share their story with you. Patient 1 is a 74-year-old female who presented with fatigable ptosis, diplopia, and dysphagia, MGFA class 3B. Her acetylcholine and striated muscle antibodies were positive, and she did undergo thymectomy. She was initially started on prednisone 30 milligrams daily, and she had a very good response to that dose. Her prednisone was then tapered down to 7.5 milligrams daily, at which time she developed myasthenic crisis twice in 2 months, and each time requiring intubation and plasmapheresis. During the second crisis, she was given rituximab 1 gram infusions 2 weeks apart, in addition to a prednisone taper. She had been complaining of right hip pain for a few months and finally underwent MRI, which revealed a right hip fracture, for which she underwent arthroplasty. At that time, prednisone was completely discontinued. However, she maintained clinical improvement at MGFA class 1. Here's a graph showing the antibody titer in blue and the CD19 percentage in orange. While we understand from Tandon's review that reduction in antibody titers may not correlate with favorable clinical responses, in this patient it seemed to correspond. As we can see, the patient received 1 gram infusions 2 weeks apart at the first arrow, and another 1 gram infusion about 6 months later. The CD19 percentage was less than 1% on 2 consecutive checks. And so based on her clinical sustained improvement, her low CD19 and her low antibody titers, the decision was made not to repeat another rituximab infusion. About 12 months after the second infusion, her CD19 percentage and antibody titers went up. However, the patient remained asymptomatic. She did not develop any symptoms until 6 months later when she relapsed with diplopia. At that time, she received another 1 gram infusion of rituximab, and she currently remains clinically improved, and she's scheduled to get another rituximab infusion this month. Patient 2 is a 67-year-old male who presented with progressive ptosis, extremity weakness, dysphagia and shortness of breath. He was MGFA class 5. He was initially transferred to our facility with concerns for Guillain-Barré syndrome, and on presentation he was intubated and initiated on plasmapheresis. His initial acetylcholine receptor antibody titer was negative. However, after a short period of discontinuation of plasmapheresis, it was found to be positive. His MuSK antibody was negative, and CT chest was negative for thymoma. A nerve conduction study confirmed a decremental response to repetitive stimulation. His hospital course was prolonged, lasting for about 3 months and requiring PEG and trach. And he had no response to prednisone, IVIG, and cyclosporin during this time. He only had a brief improvement to 9 sessions of plasmapheresis, and unfortunately, he relapsed within 1 week of discontinuation of the plasmapheresis. At that time, he was given rituximab 1 gram infusions, again, that were 2 weeks apart, and he developed pneumonia shortly afterwards, which was treated with antibiotics, but he improved to class 2A within week 40 and improved to class 1 after week 118. His trach and PEG were able to be removed, and he's doing very well currently. So in summary, we reported 6 patients with late-onset myasthenia gravis who responded well to B-cell depletion with rituximab. In our experience, rituximab was safe, it was effective, and the side effect profile was similar, if not superior, to that of chronic steroids and immunosuppression. In addition, our patients reported improved quality of life as rituximab infusions were every 6 months or less, and they were able to reduce or come off of their daily and monthly medications. We believe that B-cell depletion, specifically in older population, should be considered first-line therapy, and we hope that larger series and controlled trials will support this belief. In order to bring rituximab into routine clinical practice for the treatment of myasthenia gravis, larger studies are necessary to verify its safety and efficacy. We're currently awaiting the results of the NeuroNext phase 2 randomized control trial, in which rituximab safety and efficacy is studied in myasthenic patients on prednisone. Furthermore, there are several unanswered questions that remain, one of which is regarding the optimal rituximab regimen. In our series, the majority of patients received 1 gram infusions 2 weeks apart, which is the standard dose used in rheumatoid arthritis. And most studies use the 4 weekly infusions of 375 milligrams per meter squared, which is the standard dose used in Hodgkin's and non-Hodgkin's lymphoma. Another research question is, how often should we be retreating patients with rituximab? Do patients need to be treated regularly every 6 months, or could we potentially follow biomarkers such as antibody titers and CD19 percentage to help prolong the periods in between retreatment? While we know from Tannen's review that reduction in antibody titers has not shown to correlate with improved clinical responses, it might still be useful in some patients. In the patient that I presented earlier, we used both her antibody titers and her CD19 to hold off on retreating her for about 12 months. At that time, her markers rose, and she clinically relapsed within 6 months after that, which suggests that these biomarkers may help play a role in predicting clinical exacerbations in some patients. So with that, I'd like to thank Dr. Lewis for his guidance in this talk, and thanks for your attention. So these are really the only patients that we've done first-line rituximab so far.
Sorry, that was my question to you. Were there patients that were given Rituxan but did not respond, but I got it.
Specifically late onset, so we're kind of building our database. So we recognize that this is sort of, these are select few patients that we picked, but it's more so to kind of stimulate discussion that this may be a reasonable thought to do.
Just a compliment first for a very nice presentation. Very well done. And I think we got some nice observations from that. I do have a question for you related to other treatments. I'm a bit puzzled about whether these patients received other immunosuppressive agents, and if not, why, and maybe you could make some comments.
So one patient did receive cyclosporin, and others were on IVIG and plasmapheresis. But given the severity of the side effects to prednisone and the severity of their symptoms at that time, we chose to use rituximab instead of alternative immunosuppression that may take longer to take effect.
Just to stimulate some discussion, because I was the one who had to decide with the patient whether to do this versus, and we went through all the other immunosuppressives, and most of these patients have pretty severe disease, and so things like mycophenolate and azathioprine would take too long to help them in the short term. And so the question was, which was the one that was going to potentially work with the least side effects? And when you start comparing to cyclosporin, tacrolimus, and all the other medications, to me, this had a reasonable, and the patients tended to opt for this. The ones in the hospital didn't have a choice so much, and they were like on vents with plasma exchange, and the question was what to do. So
I might disagree that the length of time for response, might have been too long.
Just very quickly, it's very hard to withhold prednisone from patients if they're getting worse for whatever reason. Did you, when you were giving them the Rituxan, I assume if they're already on a stable dose of a high dose of prednisone, you can't withdraw it obviously quickly.
Right.
Did you ever even bump it up a little bit, understanding that can you withhold a treatment that's standard of care as well?
We didn't actually bump it up. We would either continue their current dose. Sometimes they were bumped up while in the hospital when they were in a crisis temporarily, right. And then they was always accompanied with a taper after we gave the second dose of Rituxan.
But you never gave them then another bolus of steroids after that, perhaps? I mean, it's hard, and then it's hard to know what's going to be working at that time if you did and they improved.
I think we may have done that for people who were hospitalized, right. But not consistently.
Thank you.
Yeah.
Thank you for your talk. So you looked at patients with late onset myasthenia. Did you look at younger patients also in any preliminary data, or why did you separate the groups? Do you think they behave differently? Do you think that they're more severe? Just tell me a little bit about that experience.
So they actually were presenting with more severe symptoms, and we found that the therapies that we were using for the younger patients were just not working as well for the late onset patients. And so we decided to kind of use a different approach for them.
Thank you.
Okay, thank you. We will now take a break until 10:45, and then we will reconvene. There are refreshments in the back, and we hope that you'll check out the posters and also have time to do some networking with your colleagues. Thank you.